welcome to the Natural Birth Summit. Today we're talking about labour hydrotherapy, evidence and benefits. And for that discussion, we're fortunate to have with us Liz Nutter. Hi, Liz.
Hi there.
Great to have you with us. Liz has been a board certified nurse midwife for 13 years and she practices full scope midwifery. Liz graduated from University of Portland with a BSN in 2021, an MSN from Radford University with a certificate in midwifery from Shenandoah University in 2009. She earned her doctor nursing practice degree at Frontier Nursing University in 2014. Liz was named a fellow in the American College of Nurse Midwives in 2020 and was the US Army Surgeon General's consultant for women's health nursing from 2017 to 2020. Liz is a regular speaker at the American College of Nurse Midwives conference on the subject of water birth or labour hydrotherapy. And it's great to have you with us here today, Liz.
Oh, Adam, I'm pleased to be here. Thank you so much for the opportunity.
Great. Okay, let's get started. There are several different terms used for the idea of the concept of getting into warm water in labour and birth. And it would be good if you could start by reviewing those different terms and what they mean.
Yeah, absolutely. So the first thing that I want to talk about is the tub. So getting into a bathtub is not what we're talking about because we want deep immersion, meaning that a woman, when she's sitting with her bottom on the bottom of the tub, that her breasts and her entire uterus is fully submerged in water. So that's the first point. And then we talk about whether the birth or we're laboring in water from the time of initial contractions all the way up until the point where a woman starts pushing. And that's considered water labor. When we talk about water birth, it's considered the time from when a woman's 10 centimeters or she feels that urge to push all the way through delivery of the baby actually underwater. So it's really important because there's a lot of controversy in the US around when is the ideal timing to get a woman in the tub for labor, and then is it safe to deliver a baby in the water in general.
Okay, fantastic. And so water immersion, labour hydrotherapy, water birth. Sometimes water birth is used in a more broad sense to include all those things, isn't it? So it's important to be careful when talking with providers, for example, to distinguish what you actually mean, and that's really helpful. And what does the science say about labour hydrotherapy at the moment?
Oh, so that's fantastic. There is a lot of evidence that has come out in the last about 4 years on the state of what occurs to a woman when she labors and births in water and what happens to the fetus. So I want to kind of share with you the highlights so that the audience can understand where we are in the state of the science when it comes to water birth. So the first thing we know is research is very, very clear that water labor and water birth decreases a woman's chance of needing any pharmacologic intervention. What that means is she's less likely to require any sort of IV pain medication, nitrous oxide, or an epidural for pain management. So we know that the woman is more likely to just labor on her own accord without any need for pharmacological pain management. We also know that a woman that labors or births in water is less likely to require Pitocin. So Pitocin is the synthetic hormone that we give women through IVs to help their contractions strengthen. And what the research has shown is that when there's deep immersion, when that woman is in the tub and her breasts and her uterus are fully submerged in water, there's a cascade of hormones that occurs in the body, and the contractions actually strengthen when the woman doesn't perceive that increased intensity. So this is why there's a decreased need for augmentation with Pitocin. They don't need it because their body physiologically responds to the deep immersion. Next, we know that women that elect to labor in the second stage, which is the pushing phase of having a baby, it's likely that their duration or the length of their pushing will actually be decreased or some research actually shows that there's no difference in the time. So as a midwife, it's not really important that it speeds things up. It's just, I want to make sure that it doesn't slow things down. And the evidence is really clear that either it'll be the same or it could actually speed it up a little bit.
Okay.
And so one of the things that around water labor and water birth is always talking about potential risk. So what we know with the state of the science is that women that labor or birth in water are not at an increased risk of having a postpartum hemorrhage, which is extra bleeding that would occur after the time of delivery. So we know that women are safe to labor and birth in water, and that it doesn't increase their risk of having extra blood loss after the time of delivery. One thing that the science shows is that women who labor in water are less likely to have tears in the vaginal area, tears in the labia in general. If a woman does tear, she is more likely to have first degree or second degree tears. So I'll explain what those are so that we make sure that the audience understands. First degree tears are just really superficial tears that are in the skin. So if you think about it, when you sit in a bathtub and your fingers get all pruny, that tissue is really soft. And so if a woman does tear, it's really normal for that first degree laceration to occur where the skin just kind of splits. The second degree laceration involves the superficial, shallower levels of the muscle that's in the vagina. And so if that tears, then the provider will go ahead and do those repairs out of the water. But again, it's just important to remember that in general, the woman is less likely to have lacerations. And most importantly, the worst lacerations that occur when a woman gives birth is third or fourth degree lacerations. And those are lacerations that involve the rectal muscle. And so the really good news is that the research on water birth shows you are very unlikely to experience a third or a fourth degree laceration if you elect to labor or birth in water. We also know that women aren't at increased risk of infection. So their uterus isn't at an increased risk of getting infected just because they chose to labor or birth in water. Now, importantly here, when we're talking about maternal outcomes, is the literature is really clear. Women are satisfied with their birth experience when they labor and birth in water. All of the literature that talks about the experience of women and how they labor and birth in water is called qualitative research. And that allows us to know, what are they thinking and feeling when they had this opportunity to labor and birth in water? And women explain terms like empowered, in control, a sense of awe and calm and peace when they were laboring and birthing in water. So as a midwife, that's really important to me, that the woman has the power given back to her and that she's in a space where she feels safe. The literature reports this cocooning effect that women report when they labor and birth in water, because the water kind of acts like a safe barrier, protecting them as they're able to kind of dive into their own power and birth their baby.
Right.
So now let's switch and talk a little bit about the neonate or the fetus and if there's any potential risk. So what we know is that babies that are born into water, they are not likely to have a NICU admission, so being admitted to a special care nursery or a neonatal intensive care unit. APGARS is a score that the provider team assigns to a baby at 1 minute and 5 minutes of life, and it lets us know how the baby's transitioning. And the research shows that babies that are born in water either have same APGAR scores or they're actually higher than babies that are born conventionally, not into water. So that just lets us know that these babies transition well after they're born into water. Also, the research shows that there's no increased risk of infection with a baby born into water. And then the one thing that the literature does clearly talk about that is an increased risk is there is a risk of the umbilical cord tearing at the time of delivery. This is called cord avulsion. So the providers that are providing water birth are aware of this fact that this is a potential risk. So what we do to minimize that risk is remind women, we know you're excited when the baby's born into the water, but we slowly want to bring the baby to the surface so that we avoid any tension on the umbilical cord. And if there is any evidence that the cord has torn, then the providers know what to do and how to intervene in an emergency. So the risk right now shows in the current literature to be out of every 48,000 women that deliver in water, 51 of them would have a risk of having a cord avulsion. So that risk is very, very low, but it still is a potential risk that the literature is clear about. So I just wanted to make sure that women know that that really is the current state of the science.
So that's just over 1 in 1,000, isn't it? Yeah.
Yep, correct. Yep.
Okay. Interesting. And I think a lot of mothers looking into this for the first time will have, and who are not familiar with water birth or watered labour, will have the question about a baby trying to breathe when it's not out of the water. And could you just speak to that and what the evidence says about that?
Yeah, absolutely. So the baby in the uterus is in a water-filled environment with amniotic fluid, and they are not breathing in utero. And it's really important that the water temperature when you're laboring, birthing, and water is controlled within the range of the maternal core temperature. And so your provider and your nursing team, they're going to be monitoring that for you when you're laboring and birthing in water. When a baby is normal, a low-risk pregnancy, and is born into a pool of water that is the same core temperature as the maternal core temperature, the baby doesn't sense any change in environment. And so we call this the dive reflex. The baby's born into the water and it doesn't realize that anything has changed. Once the baby comes to the surface and the cheek of the baby touches air, then there is a change that occurs just like conventional birth. When a baby is born and comes into contact with the air, the baby goes ahead and makes its first breath. So that is a protective mechanism that allows a baby to be born into water safely.
Okay, fantastic. And I think that one of the things I would like to just start a question, the assumption in all the evidence that you're reviewing is that there's a trained professional provider present. Is that correct?
Yes, that is what the current recommendations are, is that you have a provider that's aware of what the state of the science says and that they are trained and aware of what to do if there were an emergency that arises.
Okay, fantastic. Now, that's the evidence that we have so far, and that evidence, how much of that evidence has been confirmed in studies in the US, for example? Because I know that for a long time there wasn't a lot of good data in the US, but I think there is an increasing amount now. Is that correct?
Yeah, Adam, that's a fantastic question. So I'm going to kind of give us a mini history lesson. So back in 2014, the American College of Obstetricians and Gynecologists, which we refer to affectionately as ACOG in the US, and the American Academy of Pediatrics in 2014 came out with a committee opinion stating that based upon their review of the literature and the current research that was available for laboring and birthing in water, that their conclusion was that it was safe for women to labor in water. However, they felt the literature really wasn't clear about birthing in water. Okay. So American College of Nurse Midwives responded with a position statement in April of 2014 saying, we disagree. We really believe that the state of the science does show that this is a safe option for low-risk women. So women that are not having complicated pregnancies, so they don't have high blood pressure during pregnancy, they don't have diabetes of pregnancy, they don't have any chronic health conditions that would put them or their fetus at risk. So this really is an option for low-risk women, and that's what the American College of Nurse Midwives really came forward and said in their response to ACOG and AAP's statement and said, we recommend uncomplicated pregnancies with providers that are trained, as well as shared decision-making between the woman and her provider on what is the best option for them. And so as a response to that, the American College of Nurse Midwives came forward and put together a model practice template, which I was a part of that working group. And we also had the opportunity to get a lot of research going in the United States, because another piece of ACOG and AAP's committee opinion was there's not enough research in the United States. So the midwives in the United States, we rose to the occasion, and there are lots of high quality research studies that have been done in the United States since 2014. And no surprise to me as a water birth researcher that the evidence was the same evidence as was found in our international colleagues that had really researched water birth in the 1980s and 1990s. So all it did was validate that the state of the science for water labor and water birth is very stable, and that we really don't need to continue researching it because the data shows that it's a safe option for mom and babies that are low risk. And so ACOG in 2016 came out with another committee opinion, and they had said, we still believe that all women should be given an opportunity to labor in water. We don't recommend water birth. However, we realize that women with shared decision-making with their providers may elect for this option. And if they do, they should have a qualified provider that's trained in how to handle emergency situations. And they should be using a standardized evidence-based protocol to guide practice to ensure the water temperatures are controlled safely, to ensure infection control practices are in place. And that's exactly what the American College of Nurse Midwives, we work together to put this model practice template that's being used in the United States to guide practice based upon the current state of the science.
Okay, that's fantastic. So, and that's the most recent committee opinion is 2016 in the US. Okay. That's correct. Okay, great. Yes. Can we just dig into the question of low risk, the definition of low risk, because that's really seems really key to me. And I think that you mentioned some of the factors that can make you higher risk, and therefore perhaps not best not to get into water. But what else would you add to that? I mean, for example, at some point there was a criteria we had in the United Kingdom, which was if your body mass index was over 25, then you were not low risk. Now that's a very poor measure of risk, but that's what was norm. It was a norm. It was one of those non-evidenced norms that was in hospitals practice in the United Kingdom. So talk a bit about that and other aspects of risk and that might be worth considering when thinking about choices.
Yeah, Adam, I think it's funny that you bring up body mass index, because Ethel Burns, who's an amazing researcher in this area from the United Kingdom, I had the opportunity to talk with her. And one of the things that we talked about was BMI. And we both believe, so that's body mass index, how much weight do you have in comparison to your height? And so this is one of those things that has not been researched yet. But to me, it makes sense that if you're a larger woman and you have the opportunity to labor in water and birth in water where gravity is not pulling on you, you probably will have more optimal outcomes. But it is not an area that has been researched yet. And so I can tell you in the United States, in the model practice template, we said women of a BMI over 30, it should be shared decision-making between the provider and the client. Other things to consider low risk is a singleton, meaning that there's only one baby, so not twins, triplets, so no multiples, that the baby is in a head down position so that they're not breech, which is butt first, and that the baby is 37 weeks or gestation or higher. So that's considered a term pregnancy. So anybody over 37 weeks. And that when we're monitoring the fetus with a Doppler to listen to the fetal heart rate, that there's nothing concerning to the provider, that the baby is tolerating the labor process as evidenced by listening to the fetus and making sure that we don't hear any anomalies in the fetal heart rate pattern.
Okay, fantastic. I'd like to move on now to talk about how the evidence is valuable in discussion about the choices you have with potential providers. So how would you guide women, mothers to use this information and when they're looking at where and with who to birth their baby?
That's a really important question. And as a midwife, evidence-based practice is very important to me. And so evidence-based practice really is this three-pronged approach that takes the state of the science, which we kind of reviewed at a really high level. What does the evidence tell us? Is this a safe option? Is it putting moms or babies at increased risk? And the overwhelming answer to that is, for low-risk women, it is not an unsafe option for women. Then we have the patient's values. So taking into consideration what's important to the client. What type of birth experience are you looking for? Are you looking for a low intervention birth? Are you looking for a birth experience that you're going to walk out of it feeling like on top of the world and empowered? So listening as a midwife, listening to my patients' preferences and what they want. And then the clinical expertise is the last prong of this approach with evidence-based practice. And so for a provider, if they're practicing evidence-based medicine, there is a lot of research out there that they can research themselves and get updated on the state of the science, attend some trainings to become comfortable with this option. And that really is the approach to evidence-based practice. So if I was a laboring mother and I was interviewing providers to kind of decide who I wanted as my provider, I would kind of have three questions that I would ask. First, do you practice evidence-based medicine? And give them time to answer that question. I can tell you most likely the answer will be yes. Then you can let the provider know that you're really interested in having a birth experience where you have the opportunity to labor and or birth in water. So that's up to you. You can have that conversation with your provider about, do you offer intrapartum hydrotherapy where you allow women to labor in water or birth in water, and have that open conversation. And then letting them know if they do have that as an option, can you work with my preferences? Because I know water birth and hydrotherapy in labor is an evidence-based option, and I am interested in that for my birth experience. And if your provider or the practice doesn't offer hydrotherapy in labor, really advocating for this as a method that you want as an option for women. It might not be available for you at this time, but every time we have a woman speak up in the US and ask for this, so when we ask and enough people start asking, we plant those seeds that people keep coming back and saying, I know the evidence. This is evidence-based. I want this as an option. You're planting those seeds for future women and kind of doing a grassroots effort if the practice that you're currently going to deliver at doesn't have this as an option. So that's how I go about that, Adam. Did that kind of answer your question?
Yeah, it does. In that situation, I mean, you talked about how asking these questions, even if you don't get the answer you want now, you're paving the way for others in the future. To some places, it'll be a facilities problem.
Right.
So if you when you've asked that question of your provider, the answer is, well, and let's say you're looking at a hospital setting, and the answer is, well, yes, but we've got one pool or two pools and 15 rooms. So if the pool is available, then you'll be able to use it. Those are not great odds, are they? And so what's your experience or what's your understanding of, if that's the case, how can mothers advocate that or request that a temporary pool, they can bring in equipment that can be used, and how can that work? Is presumably that's a challenge for hospitals, isn't it, to accommodate someone else's equipment they brought in, it's temporary, etc. How can that work?
Yeah, so I think it'll be very dependent upon the organization and the hospital. The good news is, with the scenario that you presented, Adam, is if they already have them, they're going to be more likely to work with you. So if it's just a supply and demand issue, they're probably going to be more likely to say either, yeah, the demand's here, we need to purchase some more tubs to have these available, or willing to work with you and saying, hey, if you purchase your own tub and you bring it in and you're responsible for taking it out, we'll work with you. Again, kind of supply and demand, right? Bringing women together and having conversations about this, and as a community coming forward and just saying, we want this as an option, and I don't want to roll the dice that I walk in labor and 2 other women are using your 2 tubs. Like, again, making your desires heard, and so that the organization steps up and serves the women that they have in their community.
Okay, fantastic. That's really helpful. So we talked about, I think we've covered eligibility criteria. I think we've covered that. We've covered these conversations with providers. What would you say about, with some places, some hospitals, they've got that say they support use of water. This range of the agreement about what is appropriate. You use the word tub, I'd say pool, but that's okay. What's appropriate? What actually facilitates laboring and birthing in water? There isn't really a definition, is there, of what is a birth pool or a birth tub? And so, that's, I'm assuming that you shouldn't just accept that hey, we've got tubs and we do labor hydrotherapy. You actually want to see them, don't you? And make sure that there's space enough there and there's depth enough for actual buoyancy and freedom of movement. Is that the case, or am I overplaying that?
No, that's 100% right. Like we started off at the very beginning, the key piece in the definition for laboring and birthing in water is deep immersion. And the kind of definition that I use when I lecture and present on water birth is that's full immersion. So breasts all the way down are fully immersed. So really great point that you bring up, Adam, because there is no classic definition that's used in the United States to say what is a labor pool or a labor tub. And so they can be like, oh yeah, we do that. And you literally walk in and it's a bathtub, a standard bathtub where you sit and your belly is completely out of the water and your breasts are out of the water. That is not going to give you the physiologic effect of all the data points that I shared with you. It's going to help with comfort, but you're not going to get the full benefits. You're not going to get that hormone surge that we talked about that actually strengthens your contractions because you don't have the deep immersion. And so it's really important that you do ask, how big are your tubs? Would I be able to get into different positions? Could I get into hands and knees? Because if you're in a regular bathtub, getting into hands and knees is very, very difficult. And one of the things that's amazing about assisting and supporting women when they're laboring and birthing in water is they can get into whatever position they feel comfortable in. And that's really, really important. That's part of the process of laboring and birthing in water, is that full mobility to be able to move and listen to what your body is needing to birth your baby safely.
Yeah. Okay. Fantastic. Liz, I think that this has been an absolute pleasure. Thank you so much for sharing that,
You're
and
welcome.
having that review of the evidence. I think, and the fact that we're at this stage now where evidence is everywhere. It's not just in one country. It's not just in one setting. It's all of these different things. And as you say, there's stability there, which means that we can be confident when we talk about the state of the evidence, and that's been really helpful. So thank you very much. I'd like to give you a moment to talk about how people can follow up. Where can they go if they want to look at the evidence themselves, and how would you guide them to take next steps in that journey?
Yeah, so I facilitate a Facebook page called Water Birth Works. And so I'm constantly putting the new state of the science as it comes out there. And then I'll be providing for your audience a pamphlet that has the current state of the science in these different topics with citations of the actual articles. So that can be something that you could bring to your provider. With also these guiding questions. So it'll kind of serve as a template for you to ask questions of your provider. And then if they're unfamiliar with water birth, it's an opportunity for you to hand them this document so that they can evaluate the state of the science themselves.
That's fantastic. Okay, so we will, and they can get that through the Water Birth Works Facebook page or from somewhere else?
No, so that is going to be only for your audience. So if they click the link underneath the video, they will be able to get those PDFs and they'll be able to use that. Okay, fantastic. That's great. Liz, thank you so much. It's been really fantastic. We will come to a close, but thanks a lot. Take care. Take care.